Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's June 2025 issue. There are 3 articles that have been selected as our Editor's Choice or Highlights articles this month. The Editor's Choice this month is an original article entitled Cardiorespiratory Fitness and Mortality in Patients with Chronic Kidney Disease. It is authored by Dr. Yumi Chu from the Department of Exercise Science at the University of South Carolina in Columbia, South Carolina, and colleagues from several agencies, departments, and institutions. Persuasive evidence attests to the fact that cardiorespiratory fitness protects against cardiovascular and other diseases. To date, there is no clear consensus in the available literature whether cardiorespiratory fitness confers beneficial effects on mortality in chronic kidney disease, CKD. The seminal study by Su et al. Examines this question by drawing upon the unique strengths of the database of the Exercise and Health Outcome Study, ETHOS. This large longitudinal cohort study, based on the Veterans Affairs VA healthcare system, evaluated the association of cardiorespiratory fitness and health outcomes. Su et al. Identified more than 45,000 participants with a diagnosis of CKD and who completed an exercise treadmill test for the quantitative assessment of cardiorespiratory fitness. Based on peak metabolic equivalence, METs, achieved according to age and sex, 5 cardiorespiratory fitness groupings were defined: least fit, low fit, moderate fit, fit, and high fit. Over a follow-up of some 16 years, more than 50% of the original cohort died. With regards to such mortality, Su et al. Demonstrated that there was an inverse and stepwise association between cardiorespiratory fitness and mortality risk, with a 12% decrease in mortality risk for each 1 MET increase in cardiorespiratory fitness. Compared with the least fit group, the adjusted hazard ratio on moving progressively from low fit, moderate fit, fit to high fit individuals steadily decreased from 0.76 to 0.33. This study is the first to demonstrate a graded inverse relationship between cardiorespiratory fitness and mortality in CKD across all stages of CKD and irrespective of sex, age, and race. The strengths of this study include the size of the cohort, the reliable electronic health record of the VA healthcare system, the duration of follow-up, and the quantitative assessment of cardiorespiratory fitness. There are 3 salient implications, among others, of this study. First, CKD is considered a cardiovascular disease risk equivalent, with the dominant cause of death in CKD being cardiovascular disease. Indeed, the risk of cardiovascular disease-dependent mortality in CKD is commonly greater than the risk of CKD progressing to end-stage kidney disease. Perhaps the protective effects of cardiorespiratory fitness against mortality in CKD reflect the broad-based and overarching protective effects of cardiorespiratory fitness in cardiovascular disease in general. Second, other significant causes of mortality in CKD include infectious diseases and cancer, specific types of which are less likely to occur in individuals with high cardiorespiratory fitness. Third, because of the challenge and burden of CKD, there is a significant prevalence of depression in CKD patients, a condition that may also be ameliorated by cardiorespiratory fitness. To a considerable extent, cardiorespiratory fitness can be improved by regular physical activity, the latter being within our control. It doesn't involve the need for medications, and it is essentially without significant risk or cost. Patients with CKD, especially in its early stage, should thus be counseled on the widespread health benefits of regular physical activity, all of which may summate in the reduction of morbidity and mortality in CKD. Our first highlight article this month is an original article entitled Dialysis Transition Patterns of Chronic Kidney Disease Patients with and Without Heart Failure. It is authored by Dr. Mitchell Flagg and colleagues from Kaiser Permanente Los Angeles Medical Center in Los Angeles, California, and others from other schools and centers in Southern California. A bidirectional relationship exists between heart failure and CKD. Heart failure activates the renin-angiotensin-aldosterone system and other pressor systems, decreases renal perfusion, and not uncommonly accelerates the progression of CKD. CKD in turn may promote fluid retention, heighten blood pressure, and exacerbate anemia, all of which would exacerbate heart failure. The arrival of end-stage kidney disease during the course of CKD significantly worsens morbidity and mortality and compromises lifestyle in patients with CKD. And for most patients, chronic dialysis is employed as a therapeutic modality in the management of end-stage kidney disease. The preferred dialysis vascular access, as generally espoused by the Fistula First initiative, is an arteriovenous fistula. Once created, arteriovenous fistulas must undergo maturational growth, a 3-month or so biologic process, so as to achieve the requisite functional properties, in particular, a high fistula blood flow needed for effective dialysis. Arteriovenous fistulas thus should be placed months before the anticipated start date for hemodialysis. Patients without mature arterious venous fistulas or arteriovenous grafts who need to be started expeditiously on dialysis because of volume overload, electrolyte disturbances, uremia, or some other complication of CKD require the placement of a central venous catheter as a dialysis access. In such circumstances, patients are commonly hospitalized for catheter placement and hemodialysis initiation. Flagg et al. Questioned whether the presence of heart failure in patients with end-stage kidney disease adversely affected outcomes when these patients were initiated on hemodialysis. These investigators undertook a cross-sectional study in the Kaiser Permanente Southern California Medical Center patients who were initiated on maintenance hemodialysis between January 1st, 2007 and December 31st, 2018, comparing those patients with and without heart failure. The essential findings of Flagg et al. Were that outcomes were worse in patients with heart failure compared with those without heart failure, as reflected by higher rates of hospitalization to initiate dialysis and more frequent use of the central venous catheter. The significance of the latter finding is that initiating dialysis with a central venous fistula or graft is usually associated with increased morbidity and mortality. Interestingly, in patients with heart failure, dialysis was initiated when the estimated glomerular filtration rate was higher than those without heart failure, findings that suggest that the indications for dialysis may differ in patients with heart failure. Importantly, Flagg et al. Uncovered the adverse effects of heart failure in patients initiating hemodialysis, and they rightly emphasize that these unique challenges necessitate specially attuned strategies in managing patients with both comorbidities. Our second highlight article this month is a review article entitled Clinical Assessment of People with Obesity, Focus on Adiposity-Related Multimorbidity. It is authored by Dr. Rosanna Bianchettin and colleagues from Mayo Clinic in Rochester, Minnesota. Obesity, regarded as a global epidemic by the World Health Organization, is a risk factor for CKD and its progression to end-stage kidney disease. Obesity is also a risk factor for hypertension and type 2 diabetes, both of which are risk factors for progressive chronic kidney disease. Indeed, the vast majority of other diseases that are complications of obesity and comprehensively covered by Bianchettin et al., heart failure, coronary artery disease, atrial fibrillation, obstructive sleep apnea, hypothyroidism, dyslipidemia, metabolic dysfunction associated steatotic liver disease, and depression are individual risk factors for CKD. Bianchettin et al. Provide a masterful and detailed treatment of these and other obesity-related diseases, emphasizing obesity as the root cause of such morbidities, a focus that not only aids in the understanding of the pathogenesis of these morbidities, but fundamentally informs relevant therapeutic strategies. These adverse multi-pronged effects of obesity stem from the pathobiologic process termed lipotoxicity, wherein the accretion of lipids and their metabolites in tissue causes, among other adverse effects, oxidative stress, inflammation, mitochondrial dysfunction, endoplasmic reticulum stress, upregulations of inimical genes, and cell death. Beginning with an assessment of tools that define obesity, this review by Bianchettin et al. Marches through the various adipose-related morbidities, focusing on their diagnosis and management, and concludes with real-world clinical cases. As such, this review complements in its coverage other recent reviews on obesity published in Mayo Clinic Proceedings. Obesity through the broad-based and ramifying adverse effects of lipotoxicity sets the stage for multiple morbidities with an accompanying interdigitation and amplification of diseases and their severity. Accordingly, as persuasively emphasized by Bianchettin et al., the management of obesity-related diseases at whatever stage should encompass as one of its key strategies the management of obesity itself. You can access these highlights and editor's choice articles free of charge during the entire month of June. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage, based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the links in the gray bar at the top of the home page from the Connect menu to follow us on Facebook, X, formerly known as Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Highlights and our MCP 60 seconds video article synopses. In addition, our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website on the home page as well as through iTunes. You can also see on our home page relevant articles that celebrate our centenary. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings. We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.